Please subscribe if you're looking for straightforward medical information that might actually make a difference. You know your morning numbers better than anyone. You've watched them climb despite doing everything correctly. Medication on schedule, carbohydrates measured, exercise consistent. And still, that fasting glucose sits 20, 30, sometimes 50 points higher than it should. I'm not going to tell you it's your fault. I'm going to tell you what I've observed in clinical practice that most endocrinologists won't mention because it seems too simple to matter. I'm Dr. Baylor Scott, and over the past decade, I've noticed something in patients over 65 whose diabetes suddenly becomes harder to control. Not gradually harder, suddenly. Numbers that were stable for years start swinging wildly. The pattern shows up regardless of medication changes, regardless of diet compliance. And when I track it back, I find the same underlying factor almost every time: chronic cellular dehydration. Not the kind of dehydration that sends you to the emergency room, the kind that happens so slowly you don't notice it, the kind where your thirst mechanism stops signaling properly, where your cells are running at 85% capacity instead of full, where your insulin receptors physically cannot function the way they're designed to. Here's what changed how I treat diabetes entirely. I started asking different questions, not just about food and medication, but about fluid intake patterns. And I discovered that a significant portion of my diabetic patients over 65 are consuming less than half the water their bodies need for basic cellular function. Not because they're careless, because their physiological thirst response has degraded to the point where they can be medically dehydrated without feeling thirsty at all. The literature focuses almost exclusively on what people eat. Very little research examines when and how people hydrate. But when you understand what happens at the cellular level when someone is chronically dehydrated, you realize why their glucose numbers won't stabilize no matter how perfect everything else is. Let me explain the metabolic reality that doesn't get discussed in diabetes education classes. After age 60, 4 specific changes occur in your body that directly impact blood sugar control. These aren't theories. These are measurable physiological shifts. First, your cellular water channels deteriorate. These are proteins called aquaporins, and they're responsible for pulling water from your bloodstream into your cells. By your mid-60s, they become significantly less responsive. You can drink water, but your cells struggle to actually absorb it where it's needed. Second, your kidneys lose approximately 30% of their filtering capacity by age 70. This means 2 things. They're less effective at clearing excess glucose from your blood, and they're less efficient at concentrating your urine. You lose more water than you should every time you urinate. Third, and this is the one that surprises people, your thirst response degrades dramatically. Studies show that by age 65, the signal telling you that you need water can be delayed by 90 minutes or more after your body is already in deficit. You could be clinically dehydrated and feel completely normal. Fourth, many of the medications you're taking for diabetes and blood pressure are diuretics. They actively pull water out of your system. If you're on hydrochlorothiazide, furosemide, or even metformin at higher doses, you're losing water faster than someone not on those medications. Now here's the part that connects directly to your blood sugar. When your cells are dehydrated by even 3%, your cell membranes become rigid. Think about a dry sponge versus a wet sponge. A dry sponge can't absorb anything. It just sits there hard and unresponsive. A wet sponge pulls liquid in instantly. Your cell membranes function the same way. When they're properly hydrated, insulin receptors on the surface of your cells work normally. Insulin binds, the receptor activates, glucose channels open, and sugar moves from your bloodstream into your cells where it belongs. When those membranes are dehydrated, they stiffen. The insulin receptors don't respond properly. Your pancreas could be producing insulin, you could be injecting insulin, but if your cell membranes are rigid from chronic dehydration, that insulin cannot do its job effectively. The result is straightforward. Glucose stays trapped in your bloodstream instead of entering your cells. Your blood sugar climbs. Not because you ate the wrong thing, not because you missed a dose, because your cells physically cannot accept the glucose that's trying to enter. Let me show you what this looks like in actual practice. Robert is 69. His diabetes had been stable for 8 years. Then, without changing anything in his routine, his morning numbers went chaotic. He'd been waking up around 110 to 120 consistently. Then suddenly he's hitting 170, 185, sometimes over 200. His daughter brings him in because she's concerned. When I review his glucose log, the pattern makes no sense. Tuesday morning, 192. Wednesday, 178. Thursday, 201. Friday, 186. Same dinner every night, chicken breast, vegetables, controlled portion of brown rice, same bedtime routine, same medication schedule, but completely erratic morning readings. His daughter is leaning forward saying, "He's doing everything exactly right, Dr. Scott. I help him prepare his meals, we weigh portions. Something is clearly wrong." So I go through his typical day hour by hour. Wake time, meals, medication timing. On paper, everything looks textbook. Then I shift focus. Robert, walk me through your fluid intake on a typical day. This is where the actual pattern shows up. Well, I have coffee when I wake up, maybe a glass of water with my pills at breakfast, another glass at dinner, sometimes iced tea in the afternoon. When I ask specifically about plain water, he admits maybe 2 glasses total. I'm never really thirsty, so I don't think about it. Here's the problem. At 185 pounds, Robert needs approximately 90 ounces of water daily for basic metabolic function. He's consuming maybe 16 ounces. He's running chronically dehydrated, but his impaired thirst mechanism isn't giving him any warning signal. And coffee is a diuretic. For every 8 ounces of coffee you drink, you net about 3 ounces of actual hydration. The rest gets pulled from your body's existing water stores. We implement a structured hydration protocol. I'll explain the exact framework in a moment. Essentially, we change when, how much, and what temperature water he consumes throughout the day. 10 days later, Robert contacts me. His tone is different, lighter. Dr. Scott, my morning reading today was 118. Yesterday was 124. 3 days ago, 132. I haven't seen these numbers in 6 months. 4 weeks later, the change is visible when he walks in. Better energy, better color in his face. His glucose log shows an average fasting reading of 127 for 2 straight weeks, down from 185. Same food, same medications. The only variable that changed was hydration strategy. But here's what he tells me that matters most. I feel different, Dr. Scott. Hard to put into words, less foggy, more present. Like there was this constant mental haze I'd gotten so used to, and now it's just cleared. That mental clarity is what happens when your brain, which is 75% water, finally gets properly hydrated after months or years of running depleted. Before I give you the exact protocol, let me address the 3 mistakes nearly everyone makes with hydration after age 60. You're probably making at least 2 of these right now. Mistake 1, counting coffee, tea, and other beverages as water. Coffee and tea are mild diuretics. For every cup you drink, you lose approximately 60% of the fluid back out through increased urination. Juice and milk have calories and affect blood sugar. Soda, even diet soda, contains compounds that can interfere with insulin signaling. Plain water is the only thing that hydrates without metabolic cost. Mistake 2, drinking large amounts at once, then nothing for hours. If you drink 32 ounces of water in one sitting, your body can't process it all. Your kidneys will flush most of it out within 90 minutes. You get a bathroom trip, not cellular hydration. Cells absorb water slowly. They need consistent supply throughout the day, not occasional floods. Mistake 3, drinking cold water exclusively. Room temperature or slightly warm water absorbs significantly faster than ice-cold water. Your body has to spend energy warming cold water to body temperature before it can be used. That delays absorption and creates unnecessary metabolic work. Now, here's the protocol that produces results. I call it structured hydration for glucose control. Not a catchy name, but it's accurate. Calculate your baseline need. Take your body weight in pounds and divide by 2. That's your minimum daily ounces. If you weigh 160, you need 80 ounces minimum. If you're on diuretic medications, add 12 ounces. Divide that total into 6 drinking windows throughout the day. Not 6 glasses, 6 specific times when you drink. First window, immediately upon waking, 16 ounces of room temperature water before coffee, before anything else. Your body is already dehydrated from 8 hours of breathing and metabolic activity during sleep. This primes your cells before you add any diuretics like coffee. Second window, mid-morning, roughly 2 hours after breakfast, 12 ounces. Third window, before lunch, about 30 minutes prior, 12 ounces. Fourth window, mid-afternoon, 12 ounces. Fifth window, before dinner, 30 minutes prior, 12 ounces. Sixth window, early evening, at least 90 minutes before bed, 8 to 12 ounces. You don't want to drink too close to bedtime because you'll wake up needing to urinate, which disrupts sleep quality. Temperature matters. Room temperature or slightly warm water absorbs faster. If you prefer cold water, that's fine, but recognize it will take longer to reach your cells. Add a small amount of pink Himalayan salt or sea salt to your morning water, not table salt, roughly 1/8 of a teaspoon per 116 ounces. This provides trace minerals and helps your cells actually hold on to the water instead of flushing it immediately. Sodium is necessary for cellular water retention. If you're on a sodium-restricted diet for heart failure, skip this step. Track one thing, your morning fasting glucose. Write it down every day. After 2 weeks, look at the average. Compare it to your average from the 2 weeks before you started. That's your data point. That's what tells you if this matters for your body. If you found this information useful, please subscribe. I focus on practical interventions that actually move numbers, not theory. Thank you for watching.